Hello, I'm Dr. Han Mo Chiu of National Taiwan University Hospital. I am delighted to deliver this lecture in this 36th International Workshop on Therapeutic Endoscopy. I would like to express my sincere thanks to the organizing committee and for the very kind invitation. Today, I would like to talk about paradigm shift in the management of T1 colorectal cancer. This is the 10-year result of population-based Taiwan colorectal cancer screening program, which was launched in 2004. We observed a significant stage shifting toward the early stages, and 50% of the screen-detected colorectal cancer at first screening run, and 60% at subsequent screening run were early stage 1, which is a strong contrast to that in the unscreened group, in which nearly 80% were advanced stage cancers. That said, we are encountering more and more occasions to see T1 colorectal cancer along with the popularity of screening, which is a very good outcome if managed appropriately. Many doctors think that T1 colorectal cancer is stage 1 cancer, but this is not correct. According to US SEER database, around 10% of T1 colorectal cancer has regional lymph node metastasis, and they should be counted as stage 3 colorectal cancers. Such a risk is higher in rectal T1 cancer than in T1 colon cancers. In a meta-analysis, which was based on the analysis of surgical specimens of T1 colorectal cancer, it was demonstrated that the poor risk of regional lymph node metastasis was around 10%, which was consistent with the aforementioned data from SEER. In the same study, it was also demonstrated that T1 cancer located at rectum, pathological finding of lymphovascular invasion, deep invasion, and unfavorable histological features such as budding or poor differentiation were associated with increased risk of lymph node metastasis. This slide shows the odds of having lymph node metastasis by individual risk factor. We may see that lymphatic invasion, submucosal invasion of more than 1 mm, and the budding were some of the most important risk factors of such a risk. Some GI doctors, especially those who are not performing endoscopy treatment for large lesions, may think that if they refer all suspicious T1 cancer to surgeon, then there won't be any recurrence, but this is also not correct. According to a previous observational study in Japan, it was demonstrated that there were still recurrence and even mortality in surgically resected T1 colorectal cancer, which was 3.8% and 1.2% respectively. Although such a risk is lower than that by endoscopy resection or endoscopy resection plus surgery, we should bear in mind that we may balance between the invasiveness of treatment and the risk of recurrence. Radical surgery is more often accompanied by the risk of adverse events and morbidities. Although conducted in a large benign adenoma cohort, this study showed that undergoing surgery was associated with adverse events in nearly 60% of the patients, and 36% of them developed morbidity of class 3 or higher that require surgical intervention, multiple organ failure, or even death. If only confined with the rectal lesion, another Dutch study showed that in addition to the 40% of adverse events and the 30% of morbidity rate, stoma were created in nearly 54% of them, which might have largely affected their quality of life. Next, let's talk about the precision treatment for T1 colorectal cancer based on endoscopy finding balancing between treatment efficacy and the over-treatment risk. It is always important to balance between risk and benefit. Radical surgery is assumed to be associated with higher likelihood of curative resection, hence lower the risk of recurrence, but carries higher risk of adverse event, morbidity, and even death in some rare occasions. Endoscopic resection is a local treatment without significant damage to the organ, with lower risk of adverse event and morbidity, and also can remarkably shorten the hospital stay. The cost of these two kinds of treatment is also different if admission fee or other indirect costs are also taken into consideration. This slide shows the diagram of managing T1 colorectal cancer based on the endoscopic features. If the endoscopic features show invasive findings, then such cases should be directly referred for surgical resection. If the endoscopic features show non-invasive or equivocal findings, then we can undergo endoscopic resection first, and if pathology turns out to be deep invasive cancer or with other unfavorable findings, then additional surgery would be suggested to avoid undertreatment. It is also important to undergo endoscopic en bloc resection of the tumor in case malignant transformation is suspected, such that we can obtain a complete tissue for comprehensive pathological assessment and check whether any deep invasion or any other unfavorable histological finding is present. Recently proposed ACES algorithm by an international expert group provide a logical and a stepwise approach for evaluating colorectal nail problem. It starts from defining the gross appearance and the macroscopic classification, followed by enhanced imaging for supporting your macroscopic finding. A precise diagnosis could be made, thereby providing an optimal treatment. I won't be spending time on describing the detail of narrowband imaging classification and the Kudo pitch pattern in this presentation, but instead provide the general rule and the simplest way to estimate the invasion depth by image-enhanced endoscopy. When you see a NICE 3 or GenNet type 3 capillary pattern, such a lesion is almost deep invasive cancer that requires surgery. This has a very high specificity. If the capillary pattern is NICE 2 with GenNet 2B appearance by narrowband imaging, chroma endoscopy with crystal violet staining may be helpful in deciding the treatment. This is an 80-year-old patient with a 3 cm non-granular type LST at ascending colon near cecum. We can see the Kudo type 5 peak pattern on its surface, which is indicative of high-grade dysplasia, carcinoma in situ, or superficial T1 cancer. We performed ESD for him, and the pathology turned out to be superficial T1 cancer without any other unfavorable finding. This patient has underlying heart failure, therefore undergoing general anesthesia and colectomy would be burdensome and carry higher risk of adverse event and prolonged hospital stay. T1N0 and T1N1 colorectal cancer has comparable survival if appropriate treatment was given according to this data from Taiwan Cancer Registry. Our patient, however, would ask for the possibility of less invasive treatment or even non-surgical treatment. Therefore, we have to make clinical decisions balancing between the efficacy of treatment, minimal invasiveness, and the quality of life. On the contrary, if a T1 cancer that requires surgery is resected endoscopically, then it would cause subsequent risk of recurrence. It was reported by a Dutch study that once recurrence occurred in incompletely resected T1 cancer, then more than 40% would die from it. This slide shows the 4 subtypes of LST. Morphological classification is not just for academic interest, but could risk stratify tumor with distinct biology that require different treatment strategies. Previous meta-analysis revealed that non-granular type LST with shoulder depression carries extraordinarily higher risk of submucosal invasion, which was greater than 30%, followed by flat elevated LST-NG and the nodular mixed subtype of LST-G, which range from 5 to 10%. Homogeneous subtype of LSTG has extremely lower risk of SM invasion, which justify piecemeal resection. Moreover, non-granular type LST not only carry higher risk of submucosal invasion, but also multifocal invasion, according to a previous Japanese study. Such a finding is important because if a lesion with multifocal SM invasion is resected in piecemeal fashion, then there will be the risk of cauterization of such foci, hindering comprehensive pathological evaluation, and may expose the patient to the risk of undertreatment and the future risk of post-colonoscopy colorectal cancer. For low-risk lesions, the recurrence-free survival at 5 years was very good, which was as high as 98%, according to a previous Japanese study. In contrast, for high-risk lesions, recurrence-free survival is much lower in those who had received only endoscopic resection without additional surgery. Another study from Japan revealed that those who had high-risk histology but only underwent endoscopic resection had much higher risk of recurrence compared with those who did. Moreover, rectal T1 cancer was also associated with higher risk of recurrence should there be high-risk pathological finding. What are the current bottlenecks in the management of T1 cancers? Here is an example. This is the non-granular type LST with nodule and exceeding 7 cm in size. We performed ESD for this lesion and it was resected en bloc, as you can see here. Unexpectedly, there were totally 5 foci of high-grade dysplasia pathologically, indicating that multifocal submucosal invasion would occur should this lesion remain undetected for additional 2 or 3 years. To date, it remains still unclear at which size cutoff that we should choose ESD for such lesion, but the risk of SM invasion or multifocal invasion usually increase when the size exceeds 4 cm. Next, how should the invasion depth be measured has yet been standardized. Generally, when the muscularis mucosa layer is identifiable, invasion depth is measured from there. Spatial stain with Masson trichome would be helpful to specify the muscularis mucosa layer microscopically. If the muscularis mucosa layer is destroyed by the cancer, then we measure from the top of the lesion such that not to underestimate the depth of invasion. From this surgical pathological study from Japan, in non-pedunculated lesions like LST, there was no lymph node metastasis if the invasion depth was less than 1,000 micrometers. In pedunculated lesions, there was no lymph node metastasis when the invasion depth was less than 3,000 micrometers, justifying endoscopic resection. Hackett classification is often used in evaluating deep invasion in pedunculated lesions. In level 0, dyspratic elements are limited to the mucosa layer, and the level 1 to 4 has submucosal invasion. Level 1 denotes cancer invasion into the submucosa, but is limited to the head of the pedunculated polyp. Level 2 refers to cancer cells reaching the neck of the pedunculated polyp and usually uses the baseline for measuring vertical submucosal invasion. Budding is another important pathological finding that increases the likelihood of regional lymph node metastasis, and now there is the international consensus on tumor budding. Microscopically, if there is a single cell or tumor cell clustering up to 4 cells, we call it tumor budding, and it is an independent risk factor for regional lymph node metastasis in T1 cancers. Reporting of budding was, however, not obligated and also not standardized previously when pathologists are evaluating and reporting T1 cancers. This slide shows how budding was graded, and the grade 2 or above is deemed as a significant finding. In this consensus, they also provided the standard step to evaluate budding. If you are interested in the detail, please refer to this literature shown here. Previous NCCN guideline does not have a specific description on T1 colorectal cancer, but in the 2022 version of this guideline, unfavorable histological features are specified and highlighted. Therefore, standard of care of T1 colorectal cancer is emerging alongside the popularity of endoluminal therapies such as EMR or ESD for large colorectal neoplasm. This is the Japanese JCCR guideline published in 2016, which provides a more detailed workflow based on the pathological finding of T1 cancer. In this guideline, histology grade 3 and 4, invasion of 1000 micrometer or more, lymphatic or vascular invasion, and budding grade 2 and 3 are the indication for surgery. There is a trend of allowing deeper invasion, for example 1200 or 1500 micrometer as curative if other high-risk items are all negative, but further prospective studies are necessary. How to manage the endoscopic specimen is the key to obtain comprehensive pathological parameters to risk stratify T1 cancers. In the recent U.S. guideline, thin section of endoscopic specimen at 2 mm interval was suggested for proper pathological orientation. To make this a standard of care, we still need dialogue with the pathologist and also have to deal with the reimbursement issues in health insurance because this is a tedious and labor-intensive work. This slide summarizes what I have mentioned previously regarding the high-risk pathological finding. It is very important to confirm with pathologists about the microscopy finding because it is the endoscopy that decides whether curative resection has achieved or needs additional surgery. Here are some of the unmet clinical needs regarding the management of T1 colorectal cancer. Firstly, we need an even better way of risk stratification to further reduce over-surgery without any concession on curative treatment. Second, we still do not have a good biomarker for surveillance after endoscopic resection of T1 cancers. And finally, whether additional radiotherapy or concurrent chemoradiotherapy would be beneficial or could serve as an alternative to additional radical surgery to T1 cancer at lower rectum is another issue that worthwhile of investigation. In a recent study from Japan, it was demonstrated that blood-based liquid biopsy targeting at microRNA could provide a better risk stratification of T1 colorectal cancer with and without lymph node metastasis. It was also demonstrated that over-surgery could be reduced from 92% using the current framework to 80% using this liquid biopsy combined with clinical parameters, which was very dramatic. Herein I summarize my talk. T1 colorectal cancer is increasing nowadays, along with the popularity of screening, and its management should be standardized based on clinical evidence. The boundary of surgical and endoluminal treatment is becoming blurred. And finally, precision medicine integrating system biology and clinical big data is evolving. Thank you very much for your kind attention.